So good afternoon, everyone. Welcome to today's webinar on supervision of peers. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, housed at Rutgers School of Health Professions, the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Katy Rivera, and I'm the project coordinator of the center, and I'll be facilitating this webinar today. Next slide, please. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health and other related workforces to deliver evidence-based and empirically supported practices to individuals with mental illnesses. Please visit the MHTTC Network website for additional information at mhttcnetwork.org. Next slide, please. We also have an email listserv. We would appreciate you following this link and subscribing to receive notices about upcoming activities. And we also, in this slide, you'll see that we have upcoming webinars. Next slide, please. Before we begin the webinar, I wanted to quickly review some housekeeping items. Today's webinar is part of a series on recovery from serious mental illnesses and the practices that support recovery. We have completed 5 webinars in this series and have additional 3 webinars coming up over the next couple of months. We will post registration links for these webinars in the chat box during this webinar, and the recordings for the first 5 are available on our website. We also wanted to ask you to complete the survey that you'll receive via email following this webinar. We value this feedback and use it to improve our activities and inform future activities. The surveys are also important because our continued funding is linked to the completion of these surveys. So we thank you in advance for your feedback. Next slide, please. We also want to let you know that this webinar is being recorded and will be posted to our website. Next slide, please. Lastly, this webinar will be interactive. On your screen, you will have a taskbar with buttons that say Q&A and chat. Please use the Q&A feature to ask our presenter questions throughout the presentation. I will collect your questions as we go and ask them of the presenter during the Q&A time toward the end of the presentation. During the webinar, our presenter may pose questions to you. Please use the chat feature to answer these questions. There may also be some polling questions which will pop up on your screen where you can respond. Next slide, please. Now let's begin our webinar. We're happy to have with us Rita Cronise. Rita is the coordinator for the Academy of Peer Services Virtual Community of Practice, which is a step in the peer specialist certification for the state of New York. She has over 20 years of lived experience from the world of mutual self-help peer support, supporting many recognized leaders in the movement. Her passion is collaborating on the development of peer communities of practice, and she hopes you'll take away some of that passion from today's presentation. Next slide, please. Joanne Forbes. Ms. Forbes is currently a doctoral student in Rutgers University's Department of Psychiatric Rehabilitation. She has years of experience in the field of psychiatry as a therapist, educator, advocate, and administrator. She is a frequent presenter at conferences and is the author of the book, Madness, Heroes Returning from the Front Lines. She is one of the original founders of Baltic Street, AEH Incorporated, one of the largest national peer-run agencies. She has been widely recognized by state and national organizations as a visionary and advocate for those diagnosed with mental illness. So now we're going to turn it over to our presenters. And again, thank you for joining us.
Hello, everybody, and welcome. I echo Katy's thank you. It's lovely to see that so many of you have been able to join us on this webinar during these uncertain times. Over the next hour or so, we're going to be talking about a topic that is very current and very important for all of us to wrap our arms and our heads around in terms of understanding and contributing to what we know about the topic of peer supervision. What we hope that you learn today is something about how clinical supervision and peer supervision differ, and those implications for the current practice of peer support workers who probably supervised by non-peer professionals. And we'll also be talking about the elements needed in the supervision of peer support workers. And our hope is at the end of this presentation, we'll have time for my colleague, Rita Cronice, and her colleague, Aviva Cohen, to also present to you some of the work that's been going on for a long time behind the scenes about this topic. So just hang in with us, and hopefully we'll get you there. As Kathy had mentioned, this is meant to be an interactive webinar. So during this presentation, you'll come up to a slide that'll say, you know, we're going to chat now, and I'll be asking you a question. So here's a diagram of how to access that chat feature. This is an opportunity, even though we're not all in the same room, to share our thoughts and our ideas about this very important topic. So
Thank you, Joanne. Oh, thanks.
go ahead.
Thank you, Joanne, and I'm Rita. Thank you so much. And yes, I'm noting that it does look different. Zoom, depending on how you're approaching it, will either have the chat across the bottom, so you can hover your mouse or kind of look across the bottom of the screen, and you should see something that says a chat bubble if it's not already open on your screen. And if you do click on that, what you'll want to do is click on everybody. I guess you're not able to click on everybody. Oh, that's interesting. This is the first time I've done a webinar where we haven't been able to, oh, all panelists and attendees. So click on all panelists and attendees when you, when you go to the chat. And we would love for you to just begin this process of interacting with us. We'll be asking questions throughout the webinar at various points in time. We'll just pause and ask a question and let you respond to it. My job primarily in this webinar is to see what's going on in the chat and to share that back with Joanne so we can have a more rich discussion about it. So this very first chat, let's just start with having you, if you're able to get in, to just say your name, your location, and your role. And we can go on from there.
Okay, Rita, thank you. And I'm going to move forward while you're all doing that. It will take a few minutes. But we'll see how this goes. Okay. So the topic of today's presentation, again, is peer supervision. And we're talking a little bit today about supervision by a non-peer supervisor. You know, is it the same? Is it different? And the reason we're talking about this is because, as all of you know, fortunately, the peer support workforce has been expanding rapidly since in 2007, Medicaid declared peer support as evidence-based, and they moved forward to fund peer support services. So many of you have had an opportunity to join, if you're a peer support worker, to join the workforce. And for those of you who have been in the workforce, you have had the pleasure of inviting peer support workers to join you as you do your important work. What's interesting about the Medicaid regulations, of course, is that in those regs, we were advised that supervision of peer support workers would be handled by a mental health professional, competent mental health professional, as decided by each state. And as of today, I would say the majority of states have deemed that supervisor as someone probably with a licensed mental health professional degree. non-peer supervisors are familiar with clinical supervision. That's the model of supervision that is most widely used and understood in social work, psychology, psychiatry, psychiatric nursing, mental health, counseling. So that is what people understand when you say to them supervision. What's interesting about that is that it's not understood by people outside of the clinical world, and it may not be a way of looking at the world that is embraced by peer support workers. So what are we talking about when we say non-peer supervision? Let's make a comparison that'll help you understand that concept. Obviously, non-peer supervision is when a peer is supervised by someone who's not a peer, who has not had that lived experience. Non-peer supervisors, as I said, are generally those supervisors in professions such as psychiatry, psychology, nursing, social work, counseling. So when you look at those differences, what you see are differences, right? Those who work from lived experience, that is their working tool, have been there, done that, as we say. Their profession is built on their journey through the mental health system and their journey into recovery. For those who are non-peers, or I will say non-disclosed, they have learned about recovery and they understand the mental health system and that journey from their education and their experience. Those with lived experience, self-help groups, mutual support, the idea of mutuality is a driving force behind how they do their craft. And for people who have worked for many years in the medical model and are now transitioning to a recovery orientation, there's still that power differential. It's inherent in the medical model. When any of us go to see a practitioner, and I'll pick on doctors for now because they're very much on our mind as the heroes of the teams that are helping us through this pandemic. But when you go to see your doctor, for the most part, you decide that he's the expert. He's the person who knows best. And for the most part, the discussion isn't a two-way street. You know, the discussion is, well, what do you think we should do? As he talks to you as the client. The power differential is there. He's the expert. He knows best. You've come seeking help. Going back to lived experience, people with lived experience and who do peer support and have been part of the self-help movement, they're dual relationships, right? The people that they're with, they see in various categories. They see them outside of work. They could be friends. They could be colleagues in self-help groups. They could be working on the same advocacy committee. So dual relationships are very much a part of the lived experience. As those of you who are non-peer professionals know very, very well, boundaries, practice boundaries, is something that's drilled into everyone as they go through their schooling and enter the workforce. Boundaries are understood very well by people who have the academic training. Gets a little messy as peer support workers enter the workforce. The other quality is people in recovery understand that recovery is a choice. You can lead a horse to water, but you can't make them drink. Everyone who has entered the helping profession has entered with this burning desire to help people. And I'm pretty sure most of you have learned by now that even the most compassionate person who wants the person in front of them to get better, to get on that road to recovery, you can show them a way, but you can't make them do it. It's their choice. For those of us who've worked in that arena, we work on mutual goals, right? Our understanding of that goal may not be exactly the same understanding of the goal by our service user in front of us. And finally, those who work with their lived experience, our peer support workers, they role model the journey of recovery. They're the folks who show by their very being how it's done. For people who are not working from lived experience, who are working from academic training and experience, a lot of what guides our work is what we know as provider responsibility. And that's a big topic, and probably we could use another webinar just for that. So again, we have these two worldviews that come together as peer support workers, enter the workforce, and come together in supervision between a non-peer supervisor and a peer worker. You have the lived experience. It differs from preventional interventions, Again, what I've said, the dual relationships, the personal self-disclosure, a focus on empowerment and role modeling hope and recovery. Academic credentials. People who have education and training know so much about some of what people are struggling about, right? They've gone to school, they've studied hard, they've learned a great deal. They've gotten degrees, associates, bachelor's, graduate degrees. And that credential is a documented award by an authorized body that says that you have achieved learning outcomes relative to a given standard. And for those of you who have gone on that journey, you understand it wasn't easy to master all that knowledge, and that knowledge is important. So let's look a little bit at clinical supervision, because that, again, is most widely understood when you say supervision. Just an aside, when you look at the literature about supervision, it really makes your head spin, because although the literature is vast and robust, not a lot of agreement on exactly what supervision is and who it works for and how it's best done. But it still is accepted as a very important standard in all the professions. But for the sake of this conversation, we know some things about clinical supervision. And what we know is that it's usually done between a senior member of a certain profession. It's provided to a junior member of that same profession, an apprenticeship, if you will. The goal is to enhance professional functioning. You know, I will show you how to do this. As you know, when you come out of school, you've learned a lot, but you may not have had a lot of opportunity to put what you've learned into practice. And your supervisor is that guide, that person that says, I've done this, I've got this. I will use the been there, done that. You learn a lot through experience. And so a supervisor within that profession teaches you that profession, all the nuances and all the things that you need to understand. The other reason that clinical supervision is provided is it monitors the quality of services provided, right? It's that provider responsibility. The discussion between the supervisor and the supervisee sometimes is about, how's this going? What can we do better? Can we look at this a different way? And pragmatically, supervisors are the gatekeepers to the profession. Whether you've had a supervisor during your clinical practice in school or whether you have a supervisor on the job, those are the people who determine your future. But let's think about this. It's an apprenticeship. It's really about teaching that junior member the craft of the profession. It relies on education, again, teaching the junior member the ropes, if you will, and supporting that junior member in their journey and understanding it in a very intimate way, because that supervisor has themselves already gone through that journey of learning the craft. Again, whether it's nursing or psychology or counseling, psychiatry, whatever profession that you belong to, that's the understanding that you'll learn from a master, someone who's been there ahead of you, and you're an apprentice and you will learn from them. So let's take a break, and I'm going to invite my colleague Rita back in. Just spend a few minutes thinking about your situation and your understanding, and answer this question. In what ways do you see our peer work and clinical work the same, and how are they different?
Thanks, Joanne. And yes, please use the chat to really consider these questions. It's some of the ways that clinical work is very much like peer work, and ways that clinical work is different. And we just want to do a little bit of a comparison and contrast. And while you're answering that question, I'm going to sort of do a little bit of an out for Joanne, because I'm not sure we really positioned this at the very beginning of the webinar, but Joanne is at this point 10 days from defending her dissertation. She's been doing this work for quite a while and interviewing peer specialists for a long time now. And we'll be sharing some of the findings of her research study then. But I also wanted to let folks on the call know that Joanne has also written a book called Heroes from the Front Lines, Returning from the Front Lines. Joanne, do you want to just tell us a very quick, 2 or 3 words about the book and how that came about?
Yes, thank you, Rita. The book is called Madness, Heroes Returning from the Front Lines. And the work was a joint effort between the staff of Baltic Street AEH, which is a peer-run agency, well known in New York City and throughout the country. And the point of the book was for people's stories to be shared, people who had entered that journey of recovery and were now working and giving back to their fellow travelers. And the thought at the time, and continues to be, that so many people don't know that people can and do recover. People who are, in acute settings or in other congregate care settings who have not had that information given to them. So in conjunction with the staff, I was just the conduit. I interviewed 25 members of the staff who told their story, how they got from places of homelessness and drug addiction and despair to lives that were full. They were working, contributing, enjoying themselves, laughing, having wonderful lives. So we put this book together, and the idea was to bring that book to any place that needed that idea of peers are just the light. They show the way. You can do it too. So I am very honored to have just been the messenger. The stories are their stories. It occurs to me, this was done many, many years ago now, but it occurs to me that in some ways, those stories are like the tools that peer support workers use, right? It's that use of self that says, there's hope. Look at me. look at where I was and look at where I am, and you can do it too. So Rita, how did we make out with this chat? I'm curious.
Oh my gosh, they're going nuts in here. But it's been wonderful to just see a lot of the things that they're talking about as being the same is both are very supportive, both are caring people, that they share resources, that they just really are looking for the best interests of the people that they're working with. And some of the differences, of course, we know are the ability to share stories, the ability to help people build a robust toolkit based on their own experience. Having that lived experience is so critical. And the services to improve the quality of people's lives. So there's so much that's good that's happening on both sides, and that really is the same. And I'm scrolling through here because there's so much great information here, and I'm really glad we'll be able to save the chat. And somebody said it's very similar, although sometimes the lines get blurred, and I think we're going to be talking quite a bit about that. So I'll turn it back to you, Joanne.
Sure, thank you. And thank you everyone for joining that chat. So yes, clinical work and peer work, how are they the same? They're very much the same in that you share the goal to promote recovery in the individuals you work for. Everyone on the team comes to work with that thought. How are we going to help this person, this service user who comes before you? Very much the same. But they differ in many ways. There's differences, as we talked about earlier, in style and skills and substance, right? The skills that clinical workers bring are different skills than peer support workers bring, right? It's that lived experience versus academic experience. I'd like to share with you an example of exactly what I mean by that. I am a psychiatric nurse by profession. I have been told that I am a professional in recovery. I have had my worldview about a diagnosis of mental illness turned on its head many, many years ago by the likes of some of the pioneers, Ed Knight, Peter Ashenden, Howie Vogel, Pat Deegan, Joe Rogers. These people were my mentors, and I am forever grateful that I got my head on straight, if you will, because when I got out of school many years ago, it was very clear to me, and I was taught, that people who are diagnosed with a mental illness don't get better. We don't have a cure. They have a chronic, progressively downward spiraling disease. That's what I was taught. And for many years in the beginning of my career, I believed that. And that's what I saw. The people I worked with didn't get better. They got worse. They got more dependent. They kept coming into the hospital. But the universe had other plans for me. And one day, Ed Knight, we invited him to present. And he talked about the research on recovery that was done by Courtney Harding and George Brooks. That research is 30, 40 years old now. It's classic. If you have not read it, you must read it. It's on the reference page, which we'll provide to you, but you really, really have to read it. So my head was like, okay, there's this whole side of being diagnosed with mental illness that I wasn't aware of. And to get to the point that I'm trying to make, so the hospital where I worked, a very progressive New York City state hospital, we hired peers as customer service representatives, because that was the hot thing back then, customer service. And we sent the peers into the outpatient and inpatient units. Didn't really know what they were supposed to do, but we were all in on this idea that people could work and they could bring something to the table. So the story I want to share in terms of difference in style and substance, we had a young man who wanted to be a chef, and he was currently working in the hospital cafeteria as an apprentice. But it was clear, the peer who was working with him basically said, you know, he wants to quit his job. We're like, he can't quit his job. What was the problem? The problem was that that worker, that apprentice chef, was on this paper bag full of medications, literally a paper bag full of medications. And he had decided that he was mortified to go to work with non-peer colleagues with this paper bag full of medication. He did not know what else to do. His choice was to stop the medications, but at that point he had decided that they were helping him, or he would quit the job. Now, the clinical team was like, you know, what do? Convince him? No. The peers said, got this, met with him, helped him figure out how to put those pills for his lunchtime doses in this little brown envelope and stick it in the back of his pocket. I mean, that's an old story, and I tell it a lot because it was such a pivotal moment where I understood how much I did not know that needed to be known from people who've been there, done that, and understood those kinds of issues. So those are the differences. You know, we come to the task, excuse me, with the same goal, getting this person back on their feet, getting them out the door, getting them back to their life. But the way we approach it, it's different, and that's okay. However, when someone who has one point of view, and that being the non-peer supervisor, and the peer support worker come together in supervision, how does that work? So the question we'd like you to answer is, what challenges have you seen with non-peer supervision? And Rita, I'm handing it over to you again.
Thanks, Joanne. And this is not intended to be an us versus them kind of question. It's more a question of, you know, what happens when, you know, there's two different worldviews and somebody is supervising somebody who they don't really understand the role or have never had a chance to really understand the complexity of the role, perhaps. Have you encountered anything like that in your work? Have you been a supervisor who has been trying to supervise a new kind of role that's come into your group? Or have you been a peer specialist who's had supervision by someone who maybe doesn't really fully understand what goes into providing peer support? So just anything that you can think of that would be challenges you've seen or experiences you've had. And we'll let Joanne go on from here, but I just wanted to really invite you to add things that you may have observed or may have experienced yourselves.
Okay, thank you, everybody. So to further understand what I call this mismatch, because that's really all it is, I think we need to think about the context in which this is happening. Peer support workers and their supervisors do their work in the midst of this transition from medical model orientation to a recovery oriented orientation, right? That shift has been occurring for many years, and paradigm changes such as that's a huge magnitude paradigm change. It takes time. The medical model was the paradigm that was understood probably for hundreds of years. When Bill Anthony and peers, pioneers, talked about recovery, when Courtney Harding and George Brooks did their seminal work, it took years for that to get into the mainstream way of thinking about how we deliver care. to service users. And in fact, recently I had been doing some staff development work at another hospital, and every July we get the baby docs, I call them, because I'm convinced they're 12 years old, which says something about my age, but you know, they're very young and they're beginning their practice. And I make it a point to meet them and welcome them. These are the people who will be leading this journey to help people who have been diagnosed with mental illness. But I always manage to ask them about the work by Courtney Harding, George Brooks. And I will tell you that even to this day, they haven't heard about it. So I then take it upon myself to give them the articles, and then I follow up. And unfortunately, most of the time, the response I get is that the people in that study, and I should be telling you about the study, but there's not a shorthand way to do it, except to say when they emptied the state hospitals in 2 northeastern states, gave them an opportunity to really understand something about that diagnosis of mental illness. And they ended up looking at the population of what we used to call back ward patients. These were clients who didn't respond to psychotropic medication. You know, that first wave of deinstitutionalization, I can't say it, were all the people who responded to medication, got out of the hospital. It was a large group that did not, but they were placed in the community, and these researchers followed them for years. And what they discovered was that 67% of those back ward patients, those patients who did not respond to any of the modalities known at the time, were recovered. And what they defined as recovery was very stringent. Recovery meant they were asymptomatic, that they were no longer on any medications, they were living independently, they were socializing, and they were working. Those studies have been replicated at least 10 times around the world with the same results. That's how we found out about recovery. So it took a while for those ideas that come out of academia to really infiltrate how practice was being done. And honestly, to this day, that we're still a work in progress. You know, there's still this recovery orientation. And many of you may work in agencies where you know about recovery, it's talked about, it's in your mission statement. But implementing that in the face of an old paradigm is not as easy as the funders make it sound. So peer workers are the embodiment, if you will, of this idea of recovery, right? The President's New Freedom Commission paper, which came out again a long time ago, really said to the nation that service users and families have to drive the system. We have to share power. We have to partner with people who are living the experience. And so, you know, 2007, we were able to hire peer support workers to embody that recovery idea. Look at this person has a diagnosis of mental illness. They're in recovery and they have something very important to tell you. That's who has joined all the organizations across the United States and probably have joined the organizations that all of you on this webinar represent. So having said that, the next question we want to invite you to...
Wait, Joanne, before you move on, I wanted to process a minute for the last one.
Yes,
We had
please.
some incredibly powerful comments about, you know, kind of what they were seeing, you know, with having a non-peer supervisor. And I wanted to put this in the context today of what's happening in the world today, because there's so much more that's happening that, you know, peers are being completely removed from their ability to do one-on-one support, but are still finding ways through telehealth and other ways of staying in touch with people and helping to support them. But, you know, some of the issues that they mentioned with non-peer supervisors is a lack of awareness of trauma and the triggers that can happen with peers when they're working with people. And often that sometimes can lead to pathologizing. So you're having a breakdown, you're having issues, you're having a return of mental health symptoms, when in fact, what people may just be experiencing is stress on the job. And I want to really just put a shout out there to say there's a lot of stress on the job for everybody right now. And yes, we absolutely want to acknowledge the heroes on the front lines now that are in this crisis that we're encountering. I really wanted to just make sure that I also brought up the fact that boundaries was something that was mentioned, scope of practice was something that was mentioned, you know, there was language was a really big thing that came up in the chat, and people sometimes feeling defensive when that sort of deficit-based language that comes out of the assessment and diagnosis and treatment world, which is so essential to the ability to provide treatment services, and yet when it's not used in a context that peers would relate to, peers can feel defensive. So just sometimes it's a matter of understanding the differences in language. And I just really wanted to call out to Kristen, because she kind of put her finger on exactly what we're trying to accomplish in this and many other of these training programs, and that is how to help peers develop their skills when I don't have the skills they're trying to develop. I'll say that again. How do I help peers to develop the skills when I don't have the skills that they're trying to or need to develop? So I thought that was just really insightful and really important to bring up before we move on to this next question. As peers move into this role, the new role in non-peer organizations, what are some of the roles the peers bring? What do peers do that's different, and what do peers do that's important, and what do peers do that, you know, we want to all make sure that we're embracing? So I'll hand this back to you, Joanne.
Okay, thank you, and thank you for what you said. As I said earlier, peer support workers are the faces of recovery. They're role innovators, whether they want to be or not. You know, if you're a peer support worker and you decided that you wanted to do that work, you may have thought to yourself, I want to be a role innovator. Most of the hundreds of peers that I've talked to, that wasn't what they were thinking. You know, they were not thinking, I'm going to go into this organization and bring this very different role and way of thinking to the table. They were thinking that someone helped them see their journey. They want to walk beside someone else and help them see their journey. So peer support workers, you know, are those innovators, and they're also advocates for changes in the mental health system. And those two things I found in my study are important, and I'll refer back to them a little bit later. So what has your experience been like in receiving supervision? Has it been from a peer? Has it been from a non-peer? That's for all you peer support workers out there. Rita, would you like to add anything?
Oh, not right now. I'm just watching the chat. They're still sort of responding to the last one, so we can kind of combine these. You know, what is the role that's coming in with peer specialists as they're coming into the organizations? And then if you've been a peer or not, what's your experience been receiving supervision? Has it been from a peer or a non-peer? And I also want to give a call out to people that are supervisors now. Where are you getting your supervision from, and how does that relate to what the peer workers that you're supervising? It's kind of like the chain of every good supervisor should have their own supervision, and every one of them should have their own. So just what has your experience been like wherever you are in that chain of receiving supervision?
Okay. And Rita, would you like to share with us, you called out one of the chats that was so important to hear. Is you seeing something else that you want to share? I see that there are, you know, almost 100 people chatting away, so we can't share all of that, although that would be lovely to do.
I thought that one was really good. Ideally, peer workers need to have the ability to challenge the status quo. And then somebody else chimed in with, yes, the clinicians I work with are the other half of my caseload. I thought that was cute.
All right. Do people need another minute? Because I know it's very hard to write your thoughts and listen and then be hit with another question. So maybe we need to pause for a moment and give people a chance to catch their breath. And Rita, you'll let me know when to go on?
Sure, if I get myself off mute, I will.
Okay. See, if this were a radio program, I would be panicking because we would have dead air. You're not supposed to have dead air. So I will chat away. And Rita, I'm going to go on while you look, actually, because I want to leave time at the end of this for Rita and her colleague Aviva to share with you some really important information that's coming down the pike. So
That sounds good. I did want to mention that some of the comments that are coming in are about, the frequency of supervision, which is really important too, whether it's weekly or when and where and how, whether it's the structure of supervision, whether it's one-on-one or group, pretty free form, not structured, very structured. They're kind of popping in with different configurations of supervision, which is great too, so if you have that you want to add, go ahead.
yeah, well, that's an interesting point, and I will stop here to say, as a doctoral student, I've had the opportunity to look, as I said, at a lot of the literature about supervision. And as I said, it's kind of all over the place. We do know some things. We know that there are different kinds of supervision: administrative, educative, restorative. But one of the things that was written not too long ago by Jonathan Delman, he looked at peer supervision, and one of the things that he talked about is that frequency and structure and regularity of supervision is really key to role clarity, which, as I share my preliminary results with you, you'll see that's still a humongous issue out there. So whoever's chatting about, how often you get supervision and how regular it is and how available it is, you're onto something. I mean, the other thing that the literature agrees, and for all of us who have been supervised would also agree, is that there are key ingredients to whoever you're supervising. And the major ingredient is the relationship between the supervisor and the peer support worker in this instance. That ability to listen, availability, mutual goal setting. What are we doing here? What is this meeting about? Transparency, responsibility, and realism. In so many of the workplaces today, it's a real stretch to get a regular supervisory session. Ideally, people would like once a week. I meet with my supervisor every week. That's not always possible, and that's okay. But what's in place? What kind of availability can you offer, etc. So, key ingredients. But here are the preliminary findings from my research. And as Rita mentioned, I was blessed to speak to peer support workers around the country in a variety of settings who are being supervised by non-peer supervisors. And peer support workers like their supervisors. That's not an issue. But to a person, and understandably, peer support workers would like also to be supervised by someone who has more experience in the craft. I always pause to use a personal experience here, and all of you have this. I know you do. And if we were to ask a chat question about this, you would come up with more examples. But, you know, before I had my first child, my range of friends, of childless friends, were great. But boy, the minute that happened, I wanted to talk to people who had kids. They weren't that interesting to me before, but all of a sudden, they were the people that I needed to talk to. And if you think about your life, that's how we learn. We learn by experience, we learn by our mistakes, and we seek advice and apprenticeship in all kinds of matters from people who have done it before us. I have a friend who can cook a cake like no one's business. Yeah, I can cook a cake. They don't come out like my friend's cake. You know, so I apprentice with her. I'm somewhat of a hopeless cause, but you know, she's very patient. So that's what peer support workers are telling us. They like their current supervisors. That's not the issue, but they also need to learn from someone who's been at this craft longer than they have. The other real important finding, and again, it's not surprising, is that a supervisor's attitude is essential. Now, it was interesting to me that this came up as a significant finding, because you say to yourself, well, of course, why is this even an issue? Well, it appears to be an issue because of this incomplete role integration, that folks who are doing a brand new job are, and I'm going to use language that's descriptive in a way maybe you don't like, but they're invading the space of people who have worked together for a long time and kind of all doing the same thing and understand each other. And then you have this interloper who has a whole different worldview sometimes and is approaching the craft differently. And so what people were saying is that the supervisor's attitude can go one or two ways, right? The attitude can be negative, and a lot of what was reported was still perceived stigma, things that supervisors did not intentionally, but that still carried that, you know, you're not a clinician, you're a patient. But a supervisor's attitude was perceived as positive when it reflected respect for the peer role. Many supervisors said, I don't understand the peer role. I've never done the peer role, but I respect your role. And along with what I call positive non-judgmental communication, that kind of communication that says, you know what, teach me, or go do your craft. I've got your back. It's okay. I don't have to understand exactly what you're doing. We'll figure this out together. And that allowed for what I call autonomous functioning. Right? There were places where the supervisor's attitude wasn't quite like that. And the supervisor was very concerned about the activities of this peer support worker, what they were, what were they doing. There's still concerns. There's concerns about, unfortunately, perceived dangerousness. You hear supervisors saying, oh my God, wonder if they say something to a client and or the client, you know, tells them something and they don't recognize it for what it's really telling us. You know, so it's messy, but it can be worked through with the positive attitude, welcoming, open arms, and the ability and willingness to let the peer support worker function under your guidance. So the reason, again, that comes up is so important as a finding is the other significant finding is that role integration is very incomplete. There's some seminal work from 2006, Gates and Mandelberg and Akabas, You know, they kind of put out the guidelines for institutions and agencies. This is how you integrate peer support workers. Lovely article, lots of good ideas. And agencies are trying the best that they know how, but it's not complete yet. And so there are issues of role clarity, as I mentioned, and Rita mentioned as well. A lot of supervisors don't have any idea what the peer support worker is supposed to do. Job descriptions are unique to the setting in which they occur. A lot of settings have job descriptions, but we're finding that the job description doesn't reflect peer work, may not reflect the understanding the peer got in certification. So, you know, it's still messy. Role clarity is a process and it takes time. Role adaptation I want to mention because it was also a finding, preliminary finding. But what peers said is if they're exposed to team discussions, team meetings, rounds, whatever your agency uses to bring the team together, and they have an opportunity to listen and understand the other side, something I call perspective taking, they are then able to adapt their role to offer the information about a service user that the team needs to hear. It may not be the most important or interesting thing that you know about the service user, but it's what is needed for this team to do their work. So that role adaptation helps the peer find their place as a member of the team. Can be controversial, we could talk about that, but it's a skill that supervisors can help the peer learn, and certainly peers are learning it on the job themselves. And that practice boundary issue, again, very familiar to all of us. Those practice boundaries have to be negotiated in the workplace because informally they're understood differently in the workplace. Rita so importantly mentioned this finding, preliminary finding, the context in which we're all living across the world certainly brings this to home. But trauma-informed supervision. Clinicians have known about trauma survivors for many, many years and have learned a great deal about working with trauma survivors. What we're hearing, preliminary findings are telling us that people who use their lived experience, right? It's a different use of self than clinicians use. Clinicians can be empathetic. Clinicians can understand what the person is going through. People who are using their lived experience frequently are re-traumatized in the remembering and the retelling. And so it's a shift in some ways to think about using those trauma-informed techniques with your supervisee. We're learning that compassion fatigue, even though it's endemic in helping professions, we know that, it happens sooner and probably is more likely to happen, predictably to happen sooner in people who are working as peer support workers. There's something about moral injury that's not usually part of the supervisory discussion, but perhaps needs to be in this supervisory relationship. Peers are being exposed to situations that they feel are just wrong, and they feel helpless to prevent. And that the range of what's wrong can be very broad, but you know, people who are being medicated involuntarily, peers are tripping into situations in case management agencies where a case manager is taking advantage. There are things that happen in our professions. So preventing re-traumatization, having that discussion about what you as the peer support worker know about your triggers and your trauma. Self-care is welcome and embraced, and supervisors talk with their clients, listen to me, clients and their peer support workers about it. But it's also important that it's a universal process, that self-care is important, not just for the peers, not just for allaying our anxiety about how difficult the job may be. It's for everyone. Supportive environment goes without saying, but the supervisor is the one that generally has to take the lead on this, is the one who has to create those opportunities for perspective taking, to be the person to talk to colleagues. And you may have colleagues within your agency that really don't like this idea of peer support work. They just don't like it. They don't get it. They don't understand it. There's some fears about being replaced by peers. You look at the literature, for example, coming out of Japan. That's what their literature is talking about. And also a little bit in Ireland and England. There's a big kerfluffle about peer support workers are going to take the place of everyone else. So, you know, you may have colleagues that have those concerns, and the supervisor, you know, has that role of helping colleagues and peer support workers take perspective. Mutual learning. We're shifting from that power differential to a partnership model in supervision, right? You need to teach each other your craft. You know, this is how I see it. This is how I look at it. How do you see it? How do you look at it? Peer networking, right? Huge finding, right? Most states are not giving the opportunity to create a career ladder with a peer support worker supervisor. Someone who's been a peer is now a supervisor. So in the absence of that, the opportunity for peer support workers to talk to other peer support workers. Many of you have agencies where you only have one peer, or if you're a large agency, peers are one per team. Supervisor can create that opportunity through group supervision, through sending people to conferences, to connecting their peers with the local self-help networks, anything that helps them to learn their craft. Inside and outside of work, you know, we all need role models. We all need support. And we tend to go to our peers in whatever profession we belong or whatever situation we're talking about. Rita said, Rita has been my co-investigator, for which I am eternally grateful. And as we've talked on a weekly basis, one point, Rita said, you know, all supervision is peer supervision. You know, all of life is peer supervision, if you will. So, you know, help create that network, help create that support. And I'm bringing this in a little bit of a rush. I apologize, but I really want you to have a chance to listen to Rita and Aviva. So today was simply about thinking through what's happening, to think about your situation and where you and your agency are situated in this transformation. The mental health system's in transition. Some of you may work for agencies that are 100% recovery oriented, and I salute you. My experience working across the states is that people are getting there, but it's not that easy. It takes time. Peer support workers are the embodiment of recovery. They're on the front lines alongside of you. But lived experience and academic education and experience are not the same. And they weren't meant to be the same. So embrace those differences, celebrate those differences. You each have a lot to learn from one another. So that partnership and supervision that supervision that really mimics many of the values of recovery, you know, mutuality, walk beside me, not in front of me, not behind me. Embrace that. Peer support workers have unique supervisory needs. You know, perhaps everyone does, but people who are not disclosing, people who have been more academically educated and trained, think of supervision in a slightly different way and may not be thinking about, you know, part of my supervisory job is to help get role clarity here in this agency where I work. You know, we need to understand what this peer brings to the table and how we can work collaboratively. And last but not least, but perhaps the takeaway that you can continue to ponder is apprenticeship is the best way to learn any craft. And if, as a non-peer supervisor, you're going to have a difficult time being that mentor. There are lots of things about how the business is done and how you view what you do that's important to share. But it's not going to be the perfect fit that someone who's doing this craft of peer support work needs. So that's a lot of information in a very short time. I think I would like to hand it to Rita and Aviva, and then we will take your questions, but I'd like you to have access to this information because inherent in what Rita will share with you is like kind of down and dirty, nitty gritty. So how do I do this? Rita?
Thank you, Joanne. What a wonderful presentation. And I'm so excited that, like I said in the beginning, you're 10 days from defending your dissertation. You've put so much work into these studies. And I just wanted to give a shout out too to somebody who's in the audience who really ought to be here too, is Jonathan Edwards. He also is about ready to defend his dissertation. So I've been kind of stuck between two, doctoral students on final approach to finishing up their work. And it's been a really interesting it's been an interesting year. So I wanted to give a shout out to Jonathan because he actually has been the architect of a lot of what we're going to be showing you in a moment in regard to guidelines for supervisors. Jonathan, if you want to just in the chat share a little bit of your background, just a little bit about who you are and what you are. I'm not sure I can actually bring you on audio, but I would love to have people see, your background and where your expertise comes from. And I also wanted to introduce a colleague that's been working on a toolkit in New York City for organizational readiness. It's a needs-based toolkit for including, for the integration of peers into organizations that maybe at the beginning of the journey, somewhere in the middle of their journey, maybe towards the end of their journey, but it gives a lot of resources and ways in which the implementation of peer support within organizations can be done in a thoughtful way. Sorry. What I wanted to share, if I could share my screen, I think I might.
So Rita, I'm going to stop sharing if you're going to put something up.
Yep. Okay. What I wanted to share with everybody is an organization that I've been intimately involved in for a number of years. It's the National Association of Peer Supporters. For a time, it was known as the International Association, and at this point, they're kind of reverting back to really have more of a focus on US. I was very involved early on in the development of national practice guidelines for peer specialists, and I'm just going to open that in a new tab, so you can see what this looks like. These guidelines were developed in 2013, partly as an outgrowth to the exploration of creating a credential similar to the CPRP, but for peers. And a work group came together to define what the ethical standards were for peer specialists. So I'm just sharing my screen really quickly there. To show what these national practice guidelines look like. They are available on the INF site. They were issued in 2013. And many peer supporters know about them. They actually got more traction internationally because the World Health Organization took a look at them and included them in their quality rights training for peer specialists worldwide. But that's not really where I want to focus my attention. I might need to, I want to come back to NAPS and mention that since 2013, we've been watching with interest as more and more states have adopted Medicaid-funded peer support, and more states have required there to be clinical supervision of peers, which kind of is what Joanne has been talking about. Is this a mismatch when clinical supervisors are trying to, where is it that peers are getting their training and their ongoing learning and opportunities to really develop and improve their craft? So as NAPS was seeing more and more comments coming in about the way that supervision was happening in the workforce, a core group came together. Jonathan was part of the core group, Dana Fogelsong was part of the core work group, Kelsey Stang is part of the core work group, Jessica Wolf is part of the core work group, and Martha Barbone, all part of the core work group. We started gathering resources about supervision, and INAPS has just a wealth of information as far as resources are concerned on supervision. That you can find on the INAPS website. This is all free of charge and easily, readily accessible. We also started exploring the idea of taking those practice guidelines for peer specialists and adapting them so that there was guidance given by supervisors to those guidelines. And over the course of time, Jonathan and the work group came together and started offering tips of how a supervisor can help their peers to really stay in alignment with true peer values and do peer support in a way that's really good peer support. So these guidelines are not about necessarily how to be a supervisor, but they are about how a supervisor, the role of the supervisor in helping a peer specialist to uphold those values, the core values of peer support and what they look like in practice. So there's a lot here. I'm not going to cover it necessarily on the webinar in great detail, but there are a lot of tips that are available for supervisors on different situations. We've been doing practice, we've been doing training that has been scenario-based training using these guidelines to help train supervisors in how to really help peers to really uphold their values in practice. The thing that I'm very excited about is that my colleague Aviva Cohen has been doing work in New York City on a toolkit for helping organizations to integrate peers in the workforce. And we recognize that there could be an opportunity for creating an online tool for supervisors to use these practice guidelines in a way that's a little bit easier and more accessible than all those words. Aviva, can you unmute and talk a little bit about this process, the toolkit, and how we came about to do this?
Sure, absolutely. So as Rita mentioned, the toolkit that we created for organizational readiness is focused on providing guidelines in 9 domains of practice that we've really realized after about a year of information gathering were key areas that were presenting barriers to the integration of peers in the workforce. So primarily not allowing peers to become a valued member of the team. And one of those domains that we focused in on, in fact, was supervision. It was an area that, like many of the particular challenges mentioned throughout this webinar, pointed to issues of the boundaries between a clinical role and a supervisory role, and similarly issues about the role clarity, understanding how to support growth and development. There's another domain, in fact, that looks at the idea of career growth opportunities for peers, and in alignment with the idea of providing peer supervision from peers, we really are able to build that in and create more advancement in the role of a peer as peers can sort of take that on with their expertise that they gain over time in their roles. So similarly to the idea of the original toolkit, where we really wanted to make it needs-based and adaptable to different organizations, this reflection tool, somewhat different in that it doesn't necessarily view this as an assessment or an evaluation, but really an opportunity for the supervisor of peers to reflect on how they're supporting the peer to uphold those guidelines that were mentioned by Rita for the values of peer support. So it goes through questions and asks the supervisor to reflect on This is just a little bit of background, but also to reflect on their use of those particular practices that are intended to support the peer in the peer's role. And this also, according to the answer that is selected, will then provide a bit of information about the intended practice. So for example, if someone says, always I do this, I encourage the peer support specialists in this particular way, they'll see that that's a great opportunity. They're doing well in that area and they can draw on that strength later. Sure. So that's just an example. Contrary to that, if someone puts, not sure or never, I don't really understand what this means, they'll see a little bit more information and be able to focus in on how they can really self-reflect a bit more and monitor that in themselves over time. And it will provide those guidelines, going back to the INAP's guidelines for peer supervision. And at the end, there's also a tool to kind of reflect on this as more of a comprehensive growth opportunity over time for the supervisor, where the supervisor will really look at where they would hope to improve and has the opportunity to think about how these things manifest in practice. So not just the idea of it, but really how they can kind of experience their own areas for improvement and their own strengths, and also bring that into the conversation with the supervision. And as you see, there's also a middle ground. So as Rita clicked, somewhere in the middle, or sometimes, not all the time, there was something about using that and really drawing from that in other areas as well. So we really wanted to highlight the strengths and make that a piece of the humility that was mentioned before. Understanding that supervisors are coming from their areas of expertise, and similarly the peers have much to share, and together really building on that relationship.
Thanks, Aviva. I'm just going to click through this really quickly at this point because we're going to be doing a series of webinars too on an implementation guide that goes with the toolkit for New York City. And at this point, this prototype, this is just a prototype that we're showing you. It's not something that's actively available for the time being. This is sort of INAP's owned material, and they're going to be making sure that it's working well before it's really shared broadly, but we just wanted to give you a little bit of an idea of what INAPS has been doing in the background for a while, because we launched the practice guidelines for supervisors back in October of last year, and we have been actively looking at how we can continue to support the supervisors as well as the peer support workforce itself. So I'm trying to get to the end here. I'm sorry, Aviva, I should have gone much more quickly.
That's all right. The end is essentially that summary, that sort of a tool for reflection to look back and think about where are some areas I'd like to focus going forward as a supervisor. So here, these are all the responses. They're, you're finished entering these, and you have this opportunity to really think about a few areas. This is a summary of all of the practices that were mentioned in the INAPS guidelines, and then sort of a worksheet or a self-reflection tool to sort of hold on to over time and think about how that can be brought into the supervisory practice. Again, also focusing on the strengths.
Okay. And then, of course, many references that are available that are relevant to how this came together.
Yep.
And
so I'd just like to jump in. We have about 10 more minutes left. We want to leave room for questions about any of this.
Yep.
I really want to thank Jonathan and Rita and Aviva and their colleagues, as was mentioned, been working very hard on this, and it's such a gift to all of us. So there is a way for you to ask questions in our remaining 10 minutes. So if you'd like to just jump on that. Hey, Jonathan.
Glenn, are you able to share your screen again? I'm not sure if I can give you control back, but.
Are you talking to me?
Yeah, because I think you had the last slides up.
Okay, do you want me to back out?
Sorry, I could stay here.
All right, because as all of you may have guessed, technology is not my thing. There you go. So Rita, you can do it now?
I was not able to see the chat while I was sharing my screen, so I'm not able to answer any questions in the chat, but that's okay.
Joanne, this is Kathy. We have a few questions that came into the Q&A box and some from Jeremy Rowling. And they were mostly about academic credentialing. He stated, while lived experience and academic credentialing are a mismatch, we live in a society that values formalized education. How can we create a true career ladder when most payers want to see credentials?
Yeah. I think we're going to figure that out. It's an important question that all of us need to understand, because you're right. The impact on what organizations want to see and will vet, if you will, is that academic credential. I mean, usually is that credential that leads to a path of promotion, higher pay, etc. So the issue is a very important one. I don't have an answer, although I believe there is an answer there. We have watched our colleagues in the substance abuse arena create credentials. There certainly is a beginning in terms of certification, the work that the Academy in New York State, for example, is working on. Rita, Aviva, Jonathan, what are your thoughts on this?
Hi, this is Aviva. So I just was having, the first sort of reaction I had to this question was evaluation. So having a very clear way of measuring what we see as the core competencies and what we see as sort of the way to measure success in the role. I know that typically we also think about the amount of time in the role, but really having a more objective way to sort of think about what it is we're looking at, what we view as an advancement in the career, which is also very difficult considering the diversity of tasks and responsibilities taken on by peers across so many types of organizations. So I definitely would acknowledge that is a challenge now.
Yeah, I know there is at least one state out in the Northwest who they're working on state guidelines for competencies so that there can be a uniform understanding throughout the state, throughout all the various agencies. And their hope is that that kind of standardization will be able to pave the way for some kind of career ladder. So we'll see.
I see. Thank you so much. And then Jeremy also has another question, and it's more geared towards boundaries. And he wanted to talk a little bit more about the dynamic of dual relationships versus boundaries. He states mutuality is clearly a key component of peer support, but as long as we're offering peer support in work roles, boundaries are still important for peer supporters. He worries about the understanding of this concept among the peer workforce. Of course, boundaries are actually important for everyone outside of this context. All healthy human relationships have some boundaries. Could you talk a little bit about that?
Yeah, another real important area that we need to drill down into and understand more. The boundary issue is a challenge. It's cited throughout the literature on the barriers to integration, because peer work understands boundaries in a very different way. And I think the distinction, Jeremy, that you were pulling for there is one that we have to talk more about. One of my interviewees, I just was so inspiring. He was someone who talked about role adaptation, but he had this aha moment when he was included in team discussions, and also he started back to school. He realized that this idea of boundaries is so cemented into those who are trained academically. that part of what we're experiencing is this real paradigm conflict. And it has to be negotiated. It's what we tell people. I do trainings nationally with like Powell, whom many of you may know. He's a pioneer and a amazing trainer. But Ike basically says to the audience, you know, at this point, you have to follow your agency's boundary practices and then begin that conversation about how the peer support role is different and may not exactly fit exactly the way they're understood. So this is another, I think, arena where a lot more work has to be done. And I trust that as we go forward and learn from each other about this, we'll get to an answer that works. But it's kind of messy out there. I will share that. Does that make sense, Jeremy?
In the chat box, he had said perhaps the issues that boundaries is almost a trigger word at this point. And he says, I've never intended to think of the concept in the clinical sense of the word, but nuances are really important, and we have to make sure we allow for a lot of gray areas. So yes.
Yeah, no, you're absolutely right. It's very confusing. I started to do some work looking back at boundaries and how we evolved to our present understanding of boundaries. And the history behind this notion, if you will, probably begins with Sigmund Freud. Now, he didn't use the word boundaries, but he was the prototype for the distance that is established between the therapist and the service user. So if you look back at his work, I mean, he really wanted a blank slate. What's interesting to me, and given the fact that I've been otherwise occupied, at some point I really want to go back and look through history about how did we morph this blank slate idea into this, what almost feels like an us and them kind of territorial juggernaut. So, you know, mutuality, as we know, is healing. So we'll figure it out. I know we will. One more question before we run out of time.
Yes, thank you. We have someone, her name is Jenny Hill, and she's asking, what are your thoughts on requiring or mandating training for peer support supervisors? A colleague of hers working in Pennsylvania was required to do training as a supervision and found it very helpful.
I'm going to run out of the room screaming, I don't mandate anything as a peer.
Well, there's that. You know, a lot of peers have wished out loud that their supervisor could go through their certification training as a way to level the understanding between them. I mean, that's not exactly the same, but you know, that's been on wish lists of people that I've interviewed. I don't know.
I did want to share that supervision, the prototype that we shared just a few minutes ago, because we did a number of focus groups as we were developing the practice guidelines for supervisors, and a few supervisors said this would make a great self-assessment tool or an organizational assessment tool. And I flew that idea by a few of the peers, and they said that is against our values. That is totally against our values. We don't assess anybody. We don't even put things out there as self-assessments, you know, and that's why it became a self-reflection tool, which is really more about the person engaging with the material themselves rather than having somebody engage for them. And so that's a piece of, when we really look at this paradigm shift, we have to be very careful about how we're positioning things with mandating and required and even coercion, because that's just really truly against the values that peers represent.
Yep. Wishing out loud is not yet a
Yes.
mandate. So,
Well, so we are now at a little over an hour and a half. I just wanted to, again, thank you, Joanne, Rita, Aviva, for joining us today for our webinar, and also to our attendees. Just as a reminder, I will be sending out a evaluation link. This is how our funding, we are funded as a federal program, is on the amount of surveys that are completed. So we kindly ask that you complete them. And if you have any questions, on the email, you'll also find my contact information. If you have any comments, I can also pass them forward to our presenters.
okay.
Thanks, Kathy.
Thank you. Thank you,
Thank you,
everyone.
Thanks,
everyone.
Joanne. Thanks, Aviva. Thanks,
Thanks,
everybody.
Thanks, Aviva.
Thank you.
Everyone, be safe, be well.
Thank you.